Now I would like to invite Dr. Harshali Kamat. She's a consultant in Srinetra Eye Care, Trivandrum. She'll be talking to us on contributors to patient discontent in managing retinal disorders. Over to you, Dr. Harshali.
Good morning, everybody. I'm Dr. Harshali, and I'm going to talk to you on contributors to the patient discontent in managing the retinal disorders. So, the common diseases that we see in the retinal clinic are macular degeneration, either neovascular, non-neovascular, diabetic retinopathy, proliferative, non-proliferative, and macular edema, retinal detachments, vascular occlusions, and hereditary retinal disorders. So, as you would have noticed, there's currently no cure for most of these diseases, and the treatment goals are to slow these diseases. Now, there are several factors behind patient dissatisfaction, ranging from the medical factors, the logistical, emotional, social, environmental, and most importantly, the doctor patient relationship. Coming to the medical factors, many of these retinal diseases will be progressive despite treatment, and that leads to frustrations amongst patients as they adapt to the declining vision. There are limited treatment options, especially in the inherited diseases, the dry AMD, and that leaves the patient feeling hopeless. There's a feeling of relative ineffectiveness of treatment as treatments such as anti-VEGFs do not meet their expectations or fail to restore significant vision. Patient may have a pain or discomfort, and that can cause pain, anxiety, or fear, and that again may reduce the patient satisfaction. There are emotional factors such as lack of understanding of the disease and the treatment process, and that can stem from inadequate counseling. When we do counsel them about this irreversible loss, there's a fear of blindness. What if I go blind in the other eye too? There are unrealistic expectations, on the other hand, with the treatments that we offer. Many of these patients will have loss of reading, able to drive, and that leads to a feeling of independence, which again leads to frustration and dissatisfaction. Logistical factors such as availability of retina facilities at some centers wherein the patient may have to travel, they need a caregiver or a support system along with it, the high costs of treatment such as monthly anti-VEGFs, frequent appointments wherein the patient have to come monthly for their scanning, for their scheduling of injections, and again the long waiting time wherein they come, they get dilated, they get scanned, and all that leads to frustration. Most importantly is the doctor patient relationship. There's make sure that there is a shared decision making. Patients have to be a part of the decision making. Sometimes we are hurried in the OPD, and that the patient may perceive as a lack of empathy. There'll be some centers where different doctors will be seeing at different times and may offer different opinions, and that leads to feeling of inconsistent care. So most importantly is to set realistic expectations, explain the limitations of the treatments that are available. How does that impact the patient? A dissatisfied patient usually does not adhere to the treatment protocol. That leads to poorer outcomes, lower quality of life, a reduced trust in the healthcare provider, and reduced social activities. It does affect the physician too, with their negative reviews, lower referrals, and decrease in the patient volume. This was a survey that was conducted by the patient by Dr. Nancy, which gave a qualitative experience of patients who were receiving anti-VEGF, and that showed that patient did devote a substantial time to their treatment, and more the time that they spent, the more frustrated they were. There was another article wherein they studied not only the treatment but the disease itself, and they explored what were the patient experiences with the PDR. And many of the patients were affected with the disease affecting their daily activities like walking, their reading, writing, their concerns about future blindness, and lack of loss of independence. The treatment per se also affected them, and as compared to AMD, diabetics were more affected because it affected the younger age group, and that led to financial implications. Also, the diabetic patients had associated comorbidities like nephropathy, neuropathy, and that again led to patient dissatisfaction. So, how can we help them? You reduce the waiting times, optimize their appointments, post injections, maybe you could offer telemedicine instead of asking them to have a physical visit. Optimize the treatment protocols. Look for options such as treat and extend. Look for other drug therapies such as longer acting aflibercept or vabysmo. However, it may be a little bit expensive for them, or explore other alternative treatments such as steroids and lasers wherever possible. Address communication issues, provide clear explanation of the disease, the treatment options, and give a very realistic visual expectation. Use simple language which the patient may understand. Address their fear and anxiety of losing vision, especially in their other eye, and encourage them to participate in the decision making, not only the patient but the patient bystander also. Adequate counseling is the key. Reinforce the benefits of treatment, emphasize the potential for vision stabilization and improvement, and mainly highlight the benefits of long term treatment. So, the key strategies are realistic counseling, patient centered communication, and reduction of treatment burden by prolonging their duration of treatment and improve their clinic waiting time experience. Thank you.
Quite impressive presentation.